Welcome to this edition of AFMC.
I'll tell you how I got better. I'm
Glad to be here.
But a mission to
Delivery of
improve.
I think that we're going to talk about everybody's.
Arkansas is the second highest prescriber.
Welcome to AFMC TV. I'm Robin Ledbetter. Thanks for joining us. Today I have with me Justin Villines, and he is the HIT Policy Director for SHARE, and Anne Santifer, who is the Executive Director of SHARE. Thank you guys for being here.
Thank you for having us.
So tell us a little bit about SHARE and what it is.
Yeah, SHARE is the health information exchange for the state. We are the only statewide health information exchange. And what we do is we connect to providers' electronic medical records. We collect all that information in a central location. So then as you have encounters or visits with your different doctors, your records go with you electronically. As you can remember, back in the day, we used to have to carry papers and we'd have to go to our old doctors. We don't have to do that anymore thanks to technology.
And I think it takes the burden off of our hospitals and clinics because they're able to see that clinical data when and where they need it. So they can see updated labs and radiology reports at that time of care, which, saves our, money, but also healthier patients, healthier Arkansans.
And less duplication of services too. I think that's super important to talk about because if your doctor has access to your previous record, then they're less likely to recommend that test or procedure to be redone, which it's an expense to us as consumers because we may get stuck with co-pays and co-insurance and all that.
And we work with our providers, in health systems that have a treatment, payment, or operational need. I think that's important, when we're dealing with all the clinical data. As long as they have those, needs, then that information's available to them.
And this is just state within Arkansas.
Just within Arkansas, we do have connections with our HIE partners in surrounding states because we know people travel and they get sick when they travel. So we rely heavily on zip codes for your home address. So if somebody goes to an Oklahoma hospital, they see an Arkansas zip code, then they send that information to us and then we have the same deal with them. So if we see an Oklahoma zip code, we send that information to them.
And there is a new movement with Health Information Exchange. What does that mean?
Yeah, so health information exchanges have been around for about 10, 15 years now, and it's transitioning. As technology develops, there's really been a need for data to support our state agencies. So the new movement is called the Health Data Utility. So thinking of it in HIE as a service for the community. So we connect not only to hospitals and doctors, but we also are sharing information back with the health plans. We're supporting the health department. Especially during COVID, this is really when data was highlighted, right? The need to have real-time data on what's happening in our hospitals. And then we work to support our Department of Human Services as well with their data needs or any efforts they're working on, such as the public health unwinding. We supported Medicaid with that to alert providers when their members were getting ready to lose coverage to help make folks aware of what was happening.
Yeah, and then just like our kiddos that are taken into foster care, we are alerting, and pushing out reports, alerting that pediatrician or that med peds doc that, hey, your patient has been taken in DHS custody and making them aware, but also making aware of any hospitalizations that may happen back to DHS, which is, really being that utility.
And maternal health is a part of this as well.
Maternal health is huge, and this year I think it's being highlighted. I know our governor is very passionate about maternal health, so definitely we've been talking to DHS. We've been talking to our hospitals who are going to participate in the maternal homes program. We're talking to our WIC services at the health department about supporting them and utilizing some of the products and services that we have and kind of repurposing them to meet some of those needs for maternal health. So some things we're thinking about is tracking women while they're pregnant. So if they have a hospitalization, we can alert that care provider to let them know, hey, this woman is pregnant, but they just went to the hospital last night and they're having complications, to try to help coordinate that care and improve that quality of care that person's getting.
And I think, us pushing those alerts and that report daily, especially if a woman that is pregnant go into the emergency room or has an inpatient, encounter, pushing that report to a provider so they can get it when and where they need it so they can do that transition of care. I think we're going to be able to, track them a little better and hopefully have healthier outcomes.
So you have a real-time connection to the EMR systems. How does that work, and how many are we talking about?
Yeah, currently we're connected to over 60 different electronic medical records just here in our state, right? So, and that's not everyone. You would think that, that's it, all the electronic medical record systems. No, it seems like we're connecting to a new one, every month, with our practices. So we make those real-time connections so that data is secure and that information's coming to the health information exchange. But then it's bidirectional, meaning that our practices and our hospitals have the ability to query, is there any information on Justin Villines or Anne Santifer? Bringing that information back into their medical record so that provider, that care team can see exactly what happened, not in the walls of their hospital or clinic, but outside. Mm-hmm. And so creating that bidirectional street and working with all of our vendors to be able to, our EMR vendors in our practices, I think that's where, we shine on that, at being that statewide health information exchange, and then also pushing that, really, working with them to find out what is the best workflow, how is it going to be able to be impactful. I think that's one strong point that we push for the state of Arkansas.
Yeah, and we've been pretty successful recruiting hospitals and clinics to participate and share. We have 116 hospitals connected today. We have all major hospitals that are using an electronic medical record with the exception of 4, but they're kind of in a transition period. You definitely don't want to engage with us if you're thinking about switching an EMR, because then you're going to have to do that all over again. So, but hospitals have been very open to this, and now we're having a lot of clinics because the hospitals want to know what's happening in the clinics before the folks show up. Our payers want to know, if anybody who's taking on risk. So if you are part of an ACO or you're part of a clinically integrated network where you're taking on risk, an advanced payment model, data is a really important aspect of being successful in a value-based program. So if a clinic, a provider is participating in any sort of value-based programs where they've taken on risk, they're generally coming to us and saying, we want to connect and hook up to the pipeline so we are aware what's happening to our patients outside of our walls. So we have about 3,000 clinics, but there's no shortage of clinics wanting to connect. So we have a long roster of, sometimes we have to be like, okay, Justin, we need to calm down on the recruiting because there's, there's a lot coming down the pipeline, which is good because the more people that participate, the more complete the record is. And that's less times you have to go out and look for paper records and little bitty providers to try to get that information.
And when we say providers, it's not just inclusive of primary care. It's our behavioral health providers. Mm-hmm. It is our specialists, our gastro, our dermatology. Those specialists are in some kind of value-based arrangement as well, whether they're within the state of Arkansas or maybe they're an initiative under with CMS. And so we try to keep up with all of those movements of the metrics, all of those policy directives from the feds or within our state to really be able to assist our providers in all lines to be able to accomplish the goals that they're trying to meet. And one of the big is data, right? Yeah. Getting and knowing not just what happened in the walls of your facility, but what happened outside of your facility, and how can we streamline that and get that to you so you can do gap closures, you can follow up, and you just really know what's going on with that patient.
Well, that was my next question about data. So how is it used in terms of, I see sharing within the different facilities. Is it used other ways too? Like it's like reports for the state or different things to kind of identify problems?
Yes, actually, one thing we've done to support the health department is during the pandemic, hospitals were having to submit a lot of documentation to the health department, right? Here's how many beds I have being taken up by COVID. Here's how many patients I have tested positive. We've automated a lot of that. Mm-hmm. So if a hospital is participating in SHARE now, they don't have to submit that documentation. And, the health department is not just tracking COVID. There's a lot of things they track. So flu right now. So we are sending them a daily report of everybody who's hospitalized with a flu diagnosis. We're sending them a report of everybody who's got RSV that's hospitalized. Our health plans, our health insurance plans have really come around of this idea of using data because they know if they can get that information in real time, that can expedite prior authorizations, that can expedite, claims processing, and it can help the health plans meet some of those requirements set upon by the federal government. They have to report up their diabetic population and their A1C results. Well, you don't often see A1C results in a claim, but we have it in the clinical data, so we're able to supply that to them. Or if they're working on risk adjustment, we can supply records for them to use for risk adjustment.
And is this a nationwide effort? Is this something that you see expanding outside of Arkansas?
Yeah, I think, being that health information exchange statewide, that definitely is a plus for us. And many states have. Every state in the United States has at least one health information exchange. Some states have multiple health information exchanges. I think there is a national movement to eventually connect all the dots. All those dots out there, because we're a very mobile society. We visit, we travel, things happen, and we need to know what happened and why it potentially happened and making it way back. Because like we mentioned with the value-based programs, that goes to the total cost, right? So even if they have an event outside of the state. So there's a national movement, not just within certain states, but the federal government, the Office of National Coordinator, is really pushing under TEFCA, that movement of, the new term they're using is Qualified Health Information Networks, QHINs. And so eventually what is proposed is that if you have an event outside of your state, that record can be queried and brought it back to your home HIE essentially, or anyone that may be, working on exchange of clinical data.
Yeah, and we have some plans to join a QHIN, when they're still being developed right now. The policies are being written, but once they settle all that, our goal is to join a QHIN. I think what's going to be different for us and our health plans and providers that want to use us as part of their approach to reach out to other states is the hardest part is you have to know that that person had an event. So you have to know that Justin Villines had an event somewhere else before you can ask that information. And I think Justin highlighted that that's how we differ from a lot of HIEs is we believe on the push approach. So we have rosters that we receive from the health insurance companies, from Medicaid, from Medicare, and we track those patients and we push the information out to the care team, to the provider, or to the health plan as they need it, rather than you going, okay, I know Justin went and he had an encounter, I'm going to ask Cher if there's information on it.
Okay.
And one thing too, we even track, for our providers want to know all patients, including self-pay. Great. We can do it. Providers provide us a roster, and then we send any event that may have happened, emergency room, inpatient, and so we can alert them even on those self-pay patients. So, not just working with our health plans, but those providers too.
So this is a game changer for a provider. Is there a reason why they wouldn't want to be a part of it?
Sometimes, there's limitations with their EMRs, with their electronic medical records. No two EMRs are the same. Even, we have here in Little Rock, we have our UMS who's on Epic, and Baptist is on Epic, and Children's is on Epic, but they're all set up differently. It all depends on how you contract and what modules you purchase. But most providers are open to it. We have to be cautious when we're dealing with behavioral health providers. They're a hard group to get in, to get their buy-in, but some of them have come around the idea of sharing information, and we have to meet them at their comfort level, right? We don't ever want to push somebody to do something that they're uncomfortable doing because we know they're not going to use that technology if they're not comfortable with it. So with behavioral health providers, we made a deal with them and thought, okay, you really are protective of your notes, we are not taking in any notes. That's okay. But I think, getting them, what's the nice thing is we can get medications, we can get lab results, and we can get diagnosis. Because I think those things are important for primary care and the specialists that are seeing you, so they have a better idea when they're prescribing medications or when they're talking about treatments. And there's a huge movement too about whole person care, where primary care physicians are collaborating with behavioral health and trying to think about the whole person and not separating the mental health from the physical health.
And we not only bring in the clinical data, but the demographics as well.
Yeah.
I think that's really important. And talking to our providers out there or nurses, if they don't know the updated phone number or an address to get a hold of that particular patient, it's really hard to get them back in the clinic. So with all of our different connections across the state, we're constantly updating their phone number, their address, email address if we have it as well, bringing that in to share so that then that nurse, that care team, that provider has the most up-to-date phone number so they can get a hold of that patient. And sometimes whenever I'm working with our providers, I say, that's gold, because we can have all the clinical information in the world, but if we can't get a hold of our patients, how are we making a difference? So I say, don't forget about the demographics, and that's constantly being updated within the HIE.
How receptive are insurance providers to this?
Very open to it because I think at least here in Arkansas, our health plans, our health insurance companies are very provider burden is something that they're constantly thinking about. How can we minimize how often we're going to providers requesting charts, trying to do prior auth, so automating a lot of those functions is definitely on their roadmap. Some are farther ahead than others, but that was one decision we made at Share was we shouldn't invest so much on analytics because our health plans already have invested so much in their own. It would be hard for us to compete. So we come in with the raw data that can be fed into their tools so then they can slice it and dice it. And they're only getting information on their patients because they're giving us that roster every month so we can track it for them.
Yeah. And ACOs, accountable care organizations, clinically integrated networks, they have analytic platforms as well. They provide that roster and they're managing those lives. They're part of, an agreement with the health plan here in Arkansas or with CMS. We can push that data to their analytic platform as well because they're managing those lives, those patients within their network.
And is state funding a part of this?
Well, we do receive some funding through Medicaid. So the way we are funded, it's a proportion of it comes from Medicaid, and then our providers pay to participate, and then our health insurance plans pay to participate. So between the three of them, we're able to support our operations with almost no support with state funding. So,
well, it sounds like Arkansas is doing something right.
Yes.
And this is a good thing for the state. So thank you. Thank you for coming today. I've learned a lot, given a lot of information, and I hope that the healthcare community has as well.
Great. Thanks
Thank
for
you.
having us.
Yes. And that's it for this episode of AFMC TV. Have a great day. Thanks for watching.